Hello, this is Rana Khafagy, and I'm a consultant at Ain Shams University Hospitals in Egypt. I also serve as the Pan-Arab Interventional Radiology Society Residents, Fellows, and Students Committee Chair. It's really my pleasure to start the IR Essentials series, starting with a quick introduction to the interventional radiology. So, what is interventional radiology? It is a subspecialty which provides a minimally invasive diagnosis or treatment options using imaging that is usually done on outpatient basis. So, in IR or interventional radiology, we use needles, wires, and catheters instead of the conventional surgery tools. Our patients experience shorter hospital stay and faster recovery with organ preservation and lower complication rates compared to surgery. To summarize, IR is a clinical and procedural specialty. Interventional radiology classification can be according to whether they are including vascular or non-vascular procedures, diagnostic or therapeutic procedures, or according to the image guidance, which is the ultrasound, CT, fluoroscopy, or combined guidance. For the diagnostic procedures, for example, I can quickly talk about the angiography. It's a vascular procedure where we image the blood vessels to look for any abnormalities using different contrast media. Cholangiography, it's a non-vascular procedure where we image the bile duct within the liver to look for areas of blockage, for example. And biopsy, also a non-vascular procedure where we take a tissue sample or cells from the area of interest for pathological examination. For the therapeutic procedures, starting with the vascular procedures, we've got the balloon angioplasty and stenting, aiming for opening a narrow or blocked blood vessel using a balloon with or without placement of metallic stent. Also for the endovascular aneurysmal repair, placement of endovascular stent graft across the aneurysm in order to prevent its further expansion and progression. Of course, embolization using the fluoroscopic guidance, where our purpose mainly is to plug the vessel. This abnormal vessel may be bleeding, a vessel may be a hypertrophied vessel and supplying a hypervascular structure, and the embolization can be temporary or permanent. And through embolization, we always target a specific area, sparing as much as possible from the normal parenchyma. We have got different embolics quickly. We have the coils for proximal occlusion. We've got the particles for distal occlusion or embolization. We've got the gel foam used as temporary embolic agent. We've got the liquid embolics like the glue and the sclerotherapy. And these are permanent embolics. Examples for the embolization include renal embolization for cases of renal tumors and vascular injuries like AV fistula, mesenteric and celiac embolization in cases of active GI bleeding, splenic embolization in cases of hypersplenism, bronchial embolization in cases of AV malformations or hypertrophied pathological bronchial arteries, like in these cases. We have got here a cavity on top of previous history of TB. This is a pathological bleeder, and this is post-embolization. Also, uterine artery embolization in case of fibroids and postpartum hemorrhage, like in this case. We can see here on the left side, this is the blush of the fibroid. This is post-embolization, and on the right side, also the same. Also, we've got prostatic artery embolization in cases of benign prostatic hyperplasia, preoperative embolization of bone tumors, and many other applications for the embolization. Also, for the vascular procedures, we've got the venous access insertion, like insertion of the Mahuker and Permicas, central line application, Porticas application. This is a central line. This is Permicas. This is Mahuker. Also for the vascular procedures, we've got thrombolysis, which is usually through catheter directed technique to dissolve the blood clots. Like in this case, we have having here, this is pre-thrombolysis and this is post-thrombolysis after opening of the occluded artery. The IVC filters application, like in this case, in case of lower limb DVT, for fear of progression of the thrombus into the lung. Dialysis, like I mentioned before, placement of the venous accesses, also for applying of catheters and revision and thrombolysis of the polyfunctioning AV fistulas. The TEPS is an example for joining the hepatic and the portal vein in cases of portal hypertension and end-stage liver disease. Endovenous laser ablation for varicose veins, where we place a thin laser fiber in varicose veins under ultrasound guidance for non-surgical treatment of the venous insufficiency instead of um, surgical stripping of the great saphenous vein or the short saphenous vein. Uh, After the vascular procedures, we can go for the biliary interventions, like placement of draining catheters in the biliary system to decompress the occluded biliary system, placement of biliary stent, like in this case of pancreatic cancer, where this stent placed between the within the common bile duct reaching the duodenum to bypass the obstruction. Cholecystostomy, usually performed under ultrasound guidance, where we place a pigtail catheter into the gallbladder to remove the infected bile. For the oncological or the oncology cases, we've got the chemoembolization, like in this case, where we inject chemotherapy through the feeding artery of the tumor in the HCC or the hepatocellular carcinoma. We've got the radioembolization. Instead of injecting chemotherapy, we inject the radiotherapy. We've got the radiofrequency ablation, the cryoablation, the microwave ablation. These three are usually performed under ultrasound guidance, and the first two are performed under fluoroscopic guidance. Also, we've got the GIT interventions like esophageal stenting, esophageal balloon dilatation, feeding gastrostomy, like in these images, feeding jejunostomy, balloon dilatation for any sites of tight stenosis within the GI tract. For the genitourinary interventions, most commonly are the percutaneous nephrostomy placement, like in this case. It is usually combined through ultrasound and fluoroscopic guidance to drain the urine outside. Also, we've got the double J ureteral stent placement in cases of ureteral stenosis. For the pain management, we've got the vertebroplasty, the nerve block, like here in this case, cement injection within the fractured spinal vertebra in order to restore the vertebral body height and relieve the pain. So after quickly reviewing the most common vascular and non-vascular IR procedures, we should be aware of the pre-procedural checklist. We should involve the informed consent from the patient. We should review the platelets and the INR of the patient, make sure that the renal function is eligible for the patient to have a contrast media through the fluoroscopic guidance procedures. We should review the anticoagulation status, any allergy history, especially to the contrast media, review the images, and prepare the equipment and tools needed for our procedure. The basic IR equipment that we usually use, as I mentioned before, we need needles, guide wires, introducer sheaths, diagnostic catheters, drainage catheters like pigtail catheter. So starting with the needles, we've got the access and drainage needles, we've got the biopsy needles, and the ablation needles. For the access and drainage needles, we've got the Seldinger needle and the usual access needle, and both are used for arterial puncture, venous access, and fluid aspiration like ascites pleural effusion. We've got the Sheba needle. It's a longer one, and it's usually used for the access of the biliary system for percutaneous transhepatic drainage, less commonly for the percutaneous nephrostomy. Also, it can be used for fluid aspiration, especially for the deep collections like deep abscess or fluid collection. We've got the cannula. It has two parts, the metal trocar and the plastic part of the cannula. Also, it can be used for the arteria puncture, for the venous puncture, tapping ascites and pleural effusion, and also fluid aspirations. The abocas or the angiocas is the same like the cannula but a longer one, and it can be used for the access of the percutaneous nephrostomy, for the percutaneous drainage of the transhepatic system, biliary system, also for fluid aspirations like abscess or collection, for tapping ascites and pleural effusion, especially in obese edematous patients. So now for the biopsy needles, we've got needles that are needed for the fine needle aspiration cytology to get the cells, not the tissue, and fluid sampling. Also, we can use the cannula, the abocas, we can use the spinal needle or the metal cannula, we can use the syringe. And we've got the biopsy needle, the true cut biopsy needles, where we get a tissue, part of the tissue from the area of interest for pathological examination. These needles can be manual, semi-automatic, automatic with gun. It can be also the bone biopsy needle. So you should be aware about the principles of the true cut biopsy. So any true cut biopsy needle, whether it's automatic, whether it's manual, whether it's semi-automatic, the needle has two parts, the sheath, the outer sheath metallic part, and the inner part is the needle with a slot or a groove like this. So when inserting the needle within the lesion that we need to take the tissue sample from, we first push the internal part of the biopsy needle with the groove, like in this case, and then the outer sheath slides over the needle itself. So part of the lesion will be taken within this groove, and then we go out, we withdraw the needle outside with the tissue sample or the specimen. So this is the automatic needle over the gun. Under ultrasound guidance, I target the lesion and the needle tip stands at the edge of the lesion. Then I push this button to fire the needle. On pushing this button, first this is the rest position. On pushing the button, the inner needle goes out with the groove, and then after it, the outer sheath, the metallic sheath goes over it. So one press or one push on the button, it will fire the needle like in this, the inner and then the outer over it. That's why you should stand at the tip of the lesion. So for the ablation needles, we've got the radiofrequency needles, the microwave needles, the cryoablation needles. We've got several shapes, and ablation is usually performed under ultrasound guidance or CT guidance for the tumors. Quick info for the cannula, we should be aware that it is measured, it's using the gauge scale. This is used to measure the diameter of the needles. Coming to the catheters, we've got the diagnostic catheters, the drainage catheter, and the introducer sheath. For the catheters, they are usually a hollow flexible tube that can be inserted into the body cavity, the duct, or the vessel. And these catheters are used to drain the fluids if they are a drainage catheter, or to access the feeding artery or the target vein. The catheter usually have three parts: the hub, which determine the caliber or the diameter of the catheter, the body, which determine the length of the catheter, and the tip, which determine the type of the catheter. For example, in this case, this is a pigtail catheter. The drainage catheter are usually inserted over the wire, or it can be a single puncture used for the abscess drainage, for ascites and pleural drainage, for percutaneous nephrostomy application, or percutaneous transhepatic drainage. Regarding the diagnostic catheters, we've got many catheters. They can be the usual catheters or micro catheters with different shapes according here to the tip. As I mentioned, the tip of the catheter mentions its shape. It can be Simon, it can be vertebral, it can be cobra, and these are all used through fluoroscopic guidance to navigate through the vessels to reach the target organ. For the catheters, we measure, and the sheath also, we measure it in French. Okay, so as I mentioned, for the cannula, we measure it through the gauge, and for the catheter and sheath diameters, we measure it in French units. For the guide wire, they can be micro wires, or they can be the usual wires, and once the tip of the device arrives at its destination, it acts like a guide that larger catheters can rapidly follow for easier delivery to the treatment site. And for the wires, we measure it using the inches to get the wire diameter. So the cannula would be in gauge, the catheters would be in French, the catheters and the introducer sheath, and the wires are in inch. Coming for the guidance, as I mentioned, we've got different imaging modalities that can be used to guide our procedure. For the angiographic procedures, we use the fluoroscopic guidance, and for the percutaneous procedures like ablation, like percutaneous nephrostomy application, like percutaneous transhepatic biliary drainage for biopsy, they are usually performed under ultrasound guidance or combined guidance with other modalities like fluoroscopy or CT. So regarding the ultrasound guidance, which is the most common imaging modality guidance in the interventional radiology, especially for the minimal invasive procedures or the minimal procedures, we've got the needle adapter technique, and it's usually this one is for the beginners, where we have here the adapter, and the adapter here, whenever you insert the needle within, you will be sure that you will see the tip of the needle within the isolation beam of the ultrasound. This is usually for the beginners to get the needle guide. And the freehand technique, where we hold the probe with one hand, and using the free hand, usually the right if you are righty, we insert the needle within the isolation beam. Definitely it's more difficult, but it can give an infinite range of probe and needle coordination and needs more experience. Some tips for the ultrasound guidance: you should be prepared. You should know the position of the patient and the ultrasound properly. Both the patient and the provider need to be comfortable from the start to the finishing of the procedure. Take your time to plan your access. Easiest versus the safest, I would go for the safest. The shortest track, if safe, is more preferable. So how to see the needle? First, you should fix the probe. If we're talking about the free technique, the freehand technique, you should fix the probe at the view you want, and usually with your left hand if you are a righty, and don't move it again. You should fix your left hand, and then you should advance the needle with your free hand under the ultrasound isolation beam or plane, like in this case. This is the ultrasound probe, and this is the isolation plane, and we should insert the needle in the same plane, of the ultrasound probe. We've got the transverse and the longitudinal axis. Both are valid according to the procedure you are performing. In the longitudinal axis, this is the probe in transverse plane, and we are inserting the needle from this side, so you can see the needle shaft all over the way from the start to the end, and you can go for the transverse axis. This is the probe, and you insert the needle in this case not on the side of the probe like in the longitudinal, and in this position you will see the needle like a cross section like here, not you will not see the needle shaft all over like in the longitudinal axis. And just confirming, even for the ultrasound guided biopsies or ultrasound guided procedures, generally not only for the angiographic procedures, we should also review the patient's lab tests, the CBC, the platelets, the coagulation profile, the INR, and don't forget about the informed consent from the patient. You should also assess of any radiological examinations available. Ask the patient for any history of allergy. If the patient needs antibiotic prophylaxis, some centers go for antibiotic prophylaxis before any procedure. And the general technique for the ultrasound guided biopsy, we should study the target lesion and its biopsy approach. As I've mentioned, we've got the longest and the shortest track. Go for the shortest as long as it's safe. Avoid the vessels, the biliary ducts, the renal sinuses injury. Know your needle and gun. You have to make sure that you are familiar with the needle you are using, whether it's automatic using a gun or it's a semi-automatic. Know where to stand according to the needle and according to you are going in transverse plane or longitudinal plane. The patient position accordingly should be adjusted. Of course, don't forget about the skin antisepsis. And you should first block under ultrasound guidance with lidocaine and always pleb before going with the needle to get the best results with less pain. A small incision may be if needed using a scalpel blade. In cases of fine needle aspiration, you don't need to do it, but for the biopsy using a larger needle, you may need it. And then we go for ultrasound guidance introduction of the needle. And after we take our biopsy, we should perform some local compression, especially in cases of breast biopsies to avoid any hematoma formation. And finally, skin cleaning and dressing. The fine needle aspiration cytology differs from the true cut biopsy, where we use usual needles like the syringe, and we only target the lesions to get cells on the slides and not a tissue sample. This is an example for the true cut biopsies, like liver biopsies. Usually they are focal or targeted for the focal lesions, otherwise they can be non-targeted or diffuse. In cases of staging the cirrhosis, diffuse parenchymal disease, and we need to know the reason or the etiology of this diffuse liver disease. Here, this is under ultrasound guidance. This is a focal lesion, and this is the liver. From this view, you should know that this is the longitudinal axis, not the transverse axis. I can see the needle shaft all over, and this is the best for taking the biopsies. For the technique, we use the general technique that I mentioned before, with some added steps, like we should anesthetize the capsule of the liver, not only the skin and the subcutaneous tissue. It's better to use 16 gauge needle. As I mentioned, the needles are measured in gauge, the catheters are in French, and the wires in inches. The needle tip must be always crossing the capsule to avoid injury before firing, and after the procedure we should assess the patient for any perihepatic or intraparenchymal hemorrhage. This is just an example for the true cut biopsy, which is the most common is the liver biopsy. The same for going if we are going to aspirate abnormal fluid collection. Also, don't forget to ask the patient about his CBC, to review his INR, his this, the written consent, any available data about him, the radiological findings, the patient cooperation before the procedure to see whether the patient is cooperative or he needs some sedation or he needs anesthesia. And the general technique for aspiration, also we should adjust the patient position, perform the skin antisepsis, use the lidocaine for local anesthesia. And then we advance the needle under the ultrasound guidance. Afterwards, we perform skin cleansing and dressing. And in these cases, we usually don't need incision unless we are going to insert a pigtail catheter for drainage rather than just needle aspiration. Most commonly, the site is tapping. We may use the cannula, or if the patient is edematous and obese, we can use longer axes like the abacus. We should target the most dependent area, usually in the pelvis, direct upwards to avoid kinking of the plastic part of the cannula after removing the metallic choker to get the best for the drainage. Avoid injuring the bowel. Uh, it depends according to the different centers, but usually at my center, 4 liters maximum if we are going to do a site stepping without albumin compensation. For the pleural tapping, the patient is usually sitting, leaning forward, his arm on the table. We can use better the abacus, being longer, access the patient from behind or from the side of the patient with subcutaneous and deep infiltration of local anesthesia into the pleura, of course, under ultrasound guidance. Also use the most dependent area. We introduce the needle along the superior margin of the rib better than the lower margin to avoid injury of the neurovascular bundle. 1.5 liters are the maximum to avoid pulmonary edema, and then we remove the catheter or the needle after finishing. For the abscess management, this is an abscess. We can drain it using cannula or syringe. Also, we can leave a drainage device like pigtail catheter if it's deep or it's big and needs more time to be drained. Like in this case, this is a liver abscess, and this is the pigtail inserted inside under ultrasound guidance. So before finishing, please avoid these top 10 mistakes usually done by the junior IRs. Not reviewing the images of the patient before starting the procedure, losing the wire tip control during the angiographic procedures, dilating without confirming the wire position within the target vessel or tract, the poor sterile technique to avoid infection, standing too close during the digital subtraction angiography, uh, getting more radiation, forgetting to review the anticoagulation status of the patient, wrong catheter selection, poor communication with the operator during the procedure, ignoring the patient discomfort and instability, and incomplete documentation for the patient's data. So thank you so much. And before ending my presentation, and as the chair of the FPAIRS RFS committee, I would like to invite you all to know us more. You can check our section on the PAIRS website, and you can join our PAIRS RFS Telegram public channel. Also, you can join the PAIRS membership for free, where you can get access to the PAIRS Academy and Congress virtual session recordings, the featured cases and topics, public listing in the PAIRS Doctor Finder, access to our online member networking platform, and get the benefits of CERSI Junior membership with reduced fees. And you should know that our RFS team has contributed to the PAIRS Academy with more than 100 videos through the Was Once a Beginner video series, through the IR Juniors Global Summit versions, and through our RFS session in PAIRS 2022 till 2025. Finally, uh, you should to invite you all to check our IR curriculum for the IR juniors and medical students. Version 1 and 2 are available for all the PAIRS members for free on the PAIRS website, and wait for version 3 in PAIRS 2026 Congress. Thank you so much.